Mr. Chair, Sherelle Nota will be the recording today's meeting. Thank
Okay.
you.
Thank you, Ms. Spencer. Ms. Nota, please provide the roll call.
Mr. Chair, I can do the roll call. She's not on the line.
Go ahead, Ms. Spencer, and thank you for.
Okay, Health and Education and Human Services Committee roll call. Honorable Paul Begay Jr. Honorable Pernell Halona. Honorable Carl Slater.
Delegate Slater, present.
Honorable Charlene So. Honorable Daniel So.
I'm here.
Honorable Edison Winika.
Here.
Honorable Paul Begay Jr. Honorable Pernell Halona.
Delegate Paul
Honorable
Begay.
Charlene So.
Chair, if we could get be acknowledged when we answer roll call, because I answered roll call. Apparently, I was on mute, and I thought I was called. I was counted as being there. Thank you.
Mr. Chair, you have 4 members present. Thank you.
Thank you. So we have a quorum established. Cicilla, on the book. Edison Winika, could you provide us the invocation?
Hagoshi o Turadil Vinshu Yalati Nisto tourism Behadit Nitrai Ashwinlo Nikro di Penibig Yana di Zakro tourism Peniga ko Baki Winston Dida di Penibig and the Hachin so the national Ningi Yegun is our Ipeniga as a hit lady call. So the Hachin so Yegun hidden a Tihon need to Yego like get only get our name. Because Hachin so able to say chose and what in the art our Nikanana Kobana. Obat to halit out to nita to even yet and could open yet and honestly. Because the variant, but no one need Hachin so any financially Seda is able to source in a settled up no. The Condidika Nanas needed of Bahazunda, a co-quaigi. Hajo bitch under the door to the Hachin door next day. Ivik that illness. Penja hat any to the Hachin so Yego needs a nice day, Penina. Kahona don't need to need Zunda. Dodo don't need a need. Put in the Tada put out the years and not later about wind on to that don't need our big out that il on the Hachin so and that's it. As a height, our to Yego, the gate hit how the meditation in the 8. The Kohan saw even yes, I mean, legal little call. Then she Hachin saw been 8 and the I tapa when and though to that 8 or they see it out, she saw half of needs so take it out that it means. I don't ask for in and have one law. Not Ani, Dila, Sitahagi, or Kiro Sitahagi, President or Vice President. I don't get that in the city. I don't the face mask and that. Hachin so 18 at Hagin Hamiliado, Hachin so al Yat Ehi Penia, not Aja at all Niki, Eben Ye Nanishan Hata Saint, a coke Ani Sata Nanta. khut ein det an si ti kesi do an si alla ba khun ni tni ta e ta ni nan ta khut a si ni khut a si ta chu bi zen chu ni ta si ta to ni ki khun lo de ben na se su ya ta e ta ni ya ke to de se ben da hu ta ko khai ba si kun sin ado da khun sin an khun lo ni masan do ni chi do ni ma do ni je da ti Hhs ta hanyao di ni chin to ni ze pidas ti no to da hot out de hasin so ta hulia aron da aus khan lengi to hasin so ai ai se da da ich adati ma do je do to bachya da te ka ti khana iste ki sa ti da se dan dal to ko da ai gi shin hasin so ba ni ti do le aron da di here da tini so da so ba here ni tim hasin so ko na close that a city do da so di nan say that the bit do hasin so ko thing so na close that hasin so sin so the whole say united the honni ko ado kon hin na ke da play da banasha Bahojo, hasin so sin na da no in so but do hasin so chiyan na da do play ko ba ki hunse ado kon thoda da ni tin na da is ko thon da pleo do chong bahojo ko dan ado de ya ko ni asian banasha hasin so sata ni chen da hui na la do ni ni da do to hasin so sato chen ai khain sin ban na ta to ta ni chen hoi na la to ko khai sin chen sin di ko sin ban na ta ta ni chen hoi na la to kon di ke ha zan ki khon lo se do se fo lo da di ni da bo na ta da ko hui chen ni cha ha ta do da hui chen ben di zi da ko ban na se do se follow da di ni le za do bi gata ko bini na asin sa ala asin so ni chen na ni chen hasin so ni dil ni chen begin da sa do what on sikis ko den til hondo ko ya te ho in si na da to ta to ya te ho in gate in ge another dil ni adon da hasin so ko ti ba ka ni te Sudan here, as in so bears on be. Because Hunil or even as a heart of Williado, how who needs him. It was out on Hinadi as Catholic. The nature, Ado Hajo is Yoda Himido, Hajo and Thick, which has been at L.A. Naso, if it's not these Catholic. The corn soy corrode so the another city on the Soyat that is when Soy Koro to the Zinigi, the Hanana seed on the Smigat Asai digit Jesus Christ. Amen.
Se hat lasa sila Olo san juno so das an Ingla do so dat the in ye gi gen sahit le gin juno Ingla a sheha ado kodo shikedo shedine shethezene and I kwagi koja the horsnagi a sheha committee members, do we have any announcements? If not, then we'll go straight to recognizing officials and guests on the call. Folks on the call that are part of the agenda, proposed agenda, please identify yourself.
Hi, good morning. This is Marquis Yazzie from the Navajo area IHS. Chairman, so just FYI, I believe there are some other individuals on the meeting agenda dial-in information, which seems to be incorrect. So I'm not sure if there's separate numbers, but I just wanted to bring that to your attention. Thanks.
Thank you, Mr. Yazzie. The other number is for the public hearing on apportionment plan.
Good morning, Chair. This is Sherelle. I just got off the line on that 883 number, and I did inform the other people listening in on that call the correct special meeting Hhs number. So they got that number. I just announced it earlier. Thank you, Chair.
Thank you, Ms. Nota. Thank you for being just right there with the needs of the committee. Yeah. Anybody else?
Yeah, Dea Bene, Honorable Chairman. So this is Dr. Laura Hammett.
Oh, yeah, it's Dr. Hammett. Yeah.
Okay.
Good morning, Chair. This is Michelle, Chair and committee members, Michelle Morris from India Wakes. As mentioned earlier, some of us were on the other call, and our team is logging on this call. So good morning.
Good morning. So the team was making comments on Plan 6 over there, huh?
No, actually, it was just quiet the whole time, and there was about 9 people on the other call. So I think they're all going to be jumping on pretty soon. But we emailed our report to the committee this morning. Chair.
Yes, I received it, and I think the committee members received it. Thank you, Ms. Morris. Go ahead. I didn't mean to interrupt the next person.
Good morning. This is Lieutenant Commander Erica Harker with the Indian Health Service here providing, I'm the COVID vaccine point of contact and providing assistance that Mr. Marquis Yazzie may need, and gladly here. Thank you.
Yeah, this is Mike Jensen with Utah Navajo Health System.
Yes, Bennett, Honorable Chair. This is Ethel Branch with Navajo and Hopi Families COVID-19 Relief Fund. I would like to share, I don't know if I have room on the agenda, but I'd like to share a planned Delta response program that we'd like to roll out on Monday.
Anybody else? Dr. Jill Jim, are you on the call?
Chair, we did send a message to get Dr. Jim on the call. So she's switching calls or switching lines to get on.
Okay. We'll proceed. Miss Lauren Spencer, could you review the proposed agenda with the committee?
Yes, Mr. Chair and members of the Health, Education, and Human Services Committee, and those that are listening. Proposed agenda, Health, Education, and Human Services Committee, 24th Navajo Nation Council, special meeting, August 27th, 2021, 10 a.m. presiding, Honorable Daniel Iso, Chairperson, Honorable Carl R. Slater, Vice Chairperson, placed through telecommunication. 1, call meeting to order, roll call, invocation announcements. Number 2, recognize guests and visiting officials. Number 3, Review and adopt agenda. Number 4, review and adopt the journals. There are no journals, there's none. 5, receiving report. A, COVID-19 mutated variant stands impact on Navajo Nation. Presenter, Dr. Laura Hammond, Director of Infectious Disease Program, Shiprock, John Hopkins Center for American Indian Health. Available during presentation, Dr. Jill Jim, Executive Director, Navajo Nation Department of Health. B, COVID-19 response. A, gating criteria report. Presenter Dalyazi and HCOC EPI team. B, COVID-19 fully and partially vaccinated. 1, Navajo Nation resident vaccination rates. 2, service unit and area-wide vaccination rates. Presenter Director Rosin So, IHS Navajo Area Office and HCOC Vaccine Surveillance Team. C, proposed ARPA of 2021 expenditures for COVID-19 response. 1, loss reimbursement. 2, healthcare service / PRC. 3, information technology and telehealth. 4, vaccine planning, distribution, monitoring, and tracking. Number 5, testing, contract tracing, monitoring, and mitigation. Number 6, public health workforce. 7, mental health and substance abuse prevention and treatment. 8, detect, diagnose, trace, monitor, and mitigate COVID-19 infections. Number 9, isolation and quarantine. Number 10, school screening for COVID-19. Presenter, Dr. Jill Jim, Director, Navajo Department of Health. Director, Ross and So, IHS Navajo Area Office, CEOs of 638 health facilities. D, IHS National Supply Service Center to support IHS tribal and urban Indian health programs at no cost. Presenter, Director Ross and So, IHS Navajo Area Office. 6, old business, none. 7, new business, none. 8, close of meeting announcement and adjournment. Mr. Chair, thank you.
Thank you, Ms. Spencer. Committee members, how do you wish to proceed?
Chair, now we gave motion to set the agenda.
Honorable Alder gave motions to adopt the agenda.
Thank you, Wanika.
Chair,
This is Doug. It's later.
Honorable Vice Chair Slater, you have the floor.
Thank you. I'd like to ask the motioning parties to modify their motion to include a new 5C, and it'd be a report from Ms. Ethel Branch on the Navajo COVID relief group's response to the Delta variant and increasing activities. I'd say in the next month or starting now, but an update on their group's activities essentially is what I'd like to add on as a new 5C. Thank you.
Committee members, also we had the email from Ms. Angelita Benali about 2 legislations that completed the 5-day comment period yesterday afternoon. Ms. Nota or Ms. Spencer, do you have the numbers of those legislations that are eligible for committee action today?
Mr. Chair and members of the Health, Education, Human Services, the legislation number 17621 is not eligible for action until August 31st. Thank you.
Okay, there was, committee members, please excuse my, okay. We'll just go with Ms. Spencer's advice with committee members. The only request is to add the item of the Navajo Hopi COVID relief. Committee members, back to you. Such moving party, Honorable Paul Begay, second to the motion, Honorable Edison Wanika.
Chair, I will agree with modification to include Ms. Grant.
I'll be loud.
Okay, thank you. Let the record show that moving parties agree to amend the agenda with their motion to include the Navajo Hopi COVID relief. Ms. Nota, could you give us the roll call?
Okay. Honorable Paul Brigade Jr., how do you vote?
Delegate Paul Begay votes green.
Honorable Paul Brigade Jr. votes green. Honorable Pernell Halona, how do you vote? Honorable Carl Slater, how do you vote?
Green.
Honorable Carl Slater votes green. Honorable Charlene So, how do you vote? Honorable Charlene So, how do you vote? Honorable Edison J. Wanika, how do you vote?
Green.
Honorable Edison J. Wanika votes green. Honorable Pernell Halona, how do you vote? Honorable Pernell Halona, how do you vote? Honorable Charlene So, how do you vote? Honorable Charlene So, how do you vote? Honorable Chair Daniel So, you have 3 in favor, 0 opposed, and 3 not voting, which is including Chair Honorable Daniel So not voting, Honorable Charlene So not voting, and Honorable Pernell Halona not voting. Chair.
Thank you, Ms. Nota. And duly noted. So, committee members. Okay. Committee members. I just got a text from Miss Jalissa Johnson. Legislation 0173-21 0174-21 are ready for action. And they are both sponsored by yours truly.
Chair,
Yes.
aren't those the legislations we considered yesterday and passed out of the committee?
You mean Wednesday?
Yes, Wednesday. Jeez, time is compressed. Time is a flat circle.
Mr. Chair, this is Lorene. Those were already approved.
Okay. All right. Thank you. Thank you, Ms. Spencer. Yes, it's been a long week. Multiple meetings, multiple issues, complex issues. And a lot of criticism for the committee. So let's move forward then. We don't need to address those other legislation. So we'll go to item 4, review and adopt journals. There being none, we'll go to item 5, receiving report. 5A, Dr. Laura Hammett. Please give us a short course on the virus. Thank you.
Thank you, Honorable Chairman So. Adea Benig, She'e Laura Hammett Yenishe. I'm a pediatric infectious disease physician and epidemiologist, and I direct the infectious disease prevention team at the Johns Hopkins Center for American Indian Health. I also support the Navajo Nation HCOC, and my role is the co-lead on the testing coordination team for the COVID response. And thank you, Honorable Chairman So and honorable delegates for the opportunity to provide an update on the variants. With the widespread circulation of Delta variant and the recent reports of new variants, such as the Lambda variant, I think this is a question that's on many people's minds. As we've talked about before, all viruses, including SARS-CoV-2, the virus that causes COVID-19, change over time. When viruses replicate, they don't always make perfect copies of themselves, and sometimes the copies have little mistakes in them or what we call mutations. These changes can lead to new strains or variants, and most of the time the changes don't affect how the virus behaves, but that's not always the case. Sometimes the changes lead to the virus being able to spread more easily or to cause more severe disease or even to resist treatments. And if you think about a virus growing like a tree growing and branching out, each branch on the tree is a little bit different than the others. And by comparing the branches, scientists label them according to those differences. And the differences or the variants have been studied since the beginning of the pandemic. And earlier this spring, we sort of adopted a naming convention that had been adopted by the World Health Organization. So we are all familiar, of course, with the Alpha variant, the Beta variant, the Delta and the Epsilon variants. And the Delta variant is the one I think that's, on everybody's mind right now. This is the most contagious version of the coronavirus worldwide. As I mentioned on the President's Town Hall earlier this week, this has really changed the equation. This variant grows more quickly inside people's respiratory tracts and to levels that are 1,000 times higher than we were seeing with the earlier strains. And because of this, Delta spreads about 2 to 3 times faster than the original version of the virus. The conditions that made the coronavirus spread very quickly on Navajo Nation early in the pandemic are the same conditions that will contribute to this virus spreading rapidly now, especially given that the variant itself is more contagious. Anyone who's unvaccinated is at serious risk of getting sick from the Delta variant. For vaccinated people, fortunately, most people who are vaccinated and get infected, the so-called breakthrough infections, are not causing severe disease for most people because the vaccine has provided some degree of protection. It is, however, possible for vaccinated people to spread the Delta variant if they do get infected. So we really need everyone, including people who are vaccinated, to wear masks, stay home when sick, avoid large gatherings, and get tested if there are symptoms. The Lambda variant is another one that I wanted to mention because I think people may have seen that in the news. And the Lambda variant was first identified in Peru and has spread throughout South America. It's currently classified as a variant of interest by the World Health Organization, which means that public health experts are tracking it to see if it causes an increase in disease or a decrease in the effectiveness of the available diagnostic tests or vaccines or treatments. It's not yet classified as a variant of concern, and it hasn't been classified as a variant of interest or a variant of concern in the United States at this point. It has been detected in most U.S. states. However, it really accounts for a very, very small proportion of the cases because we really see dominance of Delta right now. I think everyone on the committee is aware that the Navajo Epidemiology Center established the Navajo Nation SARS-CoV-2 strain surveillance program, or the NNS3 program, earlier this year. And as part of that program, healthcare facilities throughout the Navajo Nation submit samples to the laboratory partner, which is TGen and Flagstaff. And the NNS3 program has provided really valuable information about the strains circulating on Navajo Nation, which can help guide the prevention and treatment strategies. And while that program, NNS3, has shown that Delta variant is now predominant, we have not seen any evidence of circulation of the Lambda variant here at this point. I do want to just close by saying, as long as there's uncontrolled spread of the SARS-CoV-2 virus, we're going to see more variants in the future, because that's how variants emerge, is by staying home from sick. These are the things that we need to do to control spread and limit further mutation of the virus. And I know that increased directed messaging about this, particularly about the risks of the Delta variant, and helping people to understand that, vaccination does not make you bulletproof. And if you have people who are unvaccinated around you, you need to really continue to take precautions. So I think that there are, every single person in the community who gets vaccinated is helping not only to protect themselves and their community, but they're also helping to keep hospitals from filling up with COVID-19 patients so that those beds are available for other people, and they're helping to protect more vulnerable members of the community. Hhs, thank you for the opportunity to share those remarks, and I'm happy to take questions if that's appropriate.
Thank you, Dr. Hammett. Committee members.
Chair?
Cecilia, Honorable Carl Slater, go ahead.
Thank you, Chair. And thank you, Dr. Hammett. My question is, my understanding of the guidance right now is if you think you may have been exposed, you should isolate until you get your test results back. But also it's still that 10 to 14 day timeline. Can you talk about with the Delta variant, it sounded like you said the onset is potentially faster for the contraction or showing symptoms. Are there new things that we know about that? And then also Lambda that the public should be aware of and that leadership should be aware of in terms of these timelines that we've come to know about COVID? Or how much are they changing, or are they changing?
Thank you,
Dr. Hammett.
Honorable Delegate Slater. Thank you, Honorable Delegate Slater, for that question. It is something that I think has been challenging because the guidance has evolved as we gain new information. And I think, the Navajo Nation has certainly tried to really keep up with what CDC guidance has been, and in some cases, take a more conservative approach, even if we are, worried that CDC guidance will potentially lead to increased transmission. So with the Delta variant, and the Lambda variant does seem to have some similar characteristics, but we know little about it at this time just because there have been so few cases of that in the United States. But they do seem to have somewhat similar characteristics, meaning that they can transmit very efficiently. It doesn't necessarily mean that there's any sort of change in the epidemiology of the clinical symptoms. That is similar, but what is recommended right now for close contacts is to undergo immediate testing. And then for fully vaccinated people, there is not a need to quarantine as a close contact, but they should monitor very closely for symptoms, and they should wear masks for 14 days, even around household members. I think just recognizing the fact that, if you have a vulnerable person in your household, many of us have kids younger than 12 in our household who are unprotected yet, not able to get the vaccine yet. So fully vaccinated people who have had close contact should still take those precautions. And then if they develop any symptoms, they should immediately repeat that testing. For unvaccinated people, then they really they should get that immediate testing, and they need to still complete that quarantine and monitoring for the recommended 14 days, regardless of their test result for that immediate test. And I do want to say, I think one thing that's really important right now, and that I know that Hess has been a great supporter of of, the prevention strategies that have been rolled out, but we really are trying to encourage people in the community to comply and with contact tracing efforts and to participate in those efforts, because that is truly, one of the most important things that we can do is identify if people have been a close contact of a case, and then, have the opportunity to talk with them, recommend them to be tested, and give the proper guidance so that we can avoid, somebody potentially getting asymptomatically infected, not knowing that they've, been infected, and then spreading that to other people unknowingly.
Chair, can I ask a follow-up?
Oh, Satilla, go ahead.
Thank you. So on that last point about the transmission that we are seeing right now, I don't know if you could talk about the data that you've reviewed, and then be great to get Dr. Jim in here. Says she's also supposed to be available during this presentation. I don't know if she was able to get on right now, but are we seeing it among certain age groups? And then if we are we also seeing like different levels of severity in terms of the symptoms and then maybe the mortality rates among those age groups right now? When I've seen information about who's getting infected, it seems like 80% are unvaccinated folks, and maybe about 20% are breakthrough in some instances. So I think leadership in the committee is very interested in knowing from a policy perspective that there are things we should encourage or rethink on the aspect of children 12 and under. The council passed a resolution that assigned the responsibility for the public health emergency orders and regulating how open the nation is to the executive branch. And with that said, a lot of, I think, the feedback that I've received on how schools are supporting the prevention strategies, communicating with parents, and complying with the reopening plan and the Department of Health public health emergency orders hasn't been great. And it's really overwhelming. And I wonder if at this point we need to be just encouraging school families with children younger than 12 to just not have their kids in school because we don't have vaccines available for them. And I guess on that last point, do we have an idea of when all school-age children might be eligible for vaccines? I've been hearing maybe within the school year, so I guess that'd be what, 5 and older. Is that consistent with what you're being told? I think that concludes my questions. Thank you.
Thank you,
Dr.
Honorable
Henry.
Delegate Slater. May I respond? Thank you, Chairman. So, with regard to your first question related to patterns of disease, I believe that Del Yazzie from the Epidemiology Center is on the agenda to present to the committee today, and he will have the best information on this. My impression on this is that, and what has been shared, from Dr. Jim, I don't know if she's been able to join the call. We are seeing really not school-based gatherings, but actually just other public gatherings that are contributing, whether they're faith-based gatherings or family gatherings that have contributed to clusters of disease and transmission right now. So we really have to ask people to take a step back. I know we're all ready to sort of move back into normal life and be spending time with loved ones and doing these types of activities. But with Delta being here, we really have to ask people to take a step and adhere to the limitations on size of gatherings. This Delta variant, like I said, is highly transmissible and highly contagious. So when you give it the opportunity to spread, it will take that opportunity. And that can result in infection, that could be severe in unvaccinated people. But even infections in vaccinated people that, then allow them to transmit to others. So I think that's one of the critical things. as you well know, the vaccine rollout really prioritized older people and people at high risk early on, and I think we had really good acceptance of vaccines in those age groups. So those individuals, and what we've seen over time is that as they've been protected through vaccination, the proportion of cases that are occurring in younger children has gone up over time. Nationally, we see that there is an increasing proportion of children getting sick with Delta. I think this is a reflection, not necessarily that Delta somehow uniquely makes children more sick, but the fact that simply that we're seeing more cases because of Delta. If we see more cases, even if only a small fraction of those go on to, require hospitalization for children, if we just, the basic math is that if we have more cases, then we're going to see more severe cases. With regard to the question about schools, I know that Dr. Jim can probably speak to this as well. As a pediatrician and as a parent, I strongly support in-person education. I think that there has been, unfortunately, a lot of hardship for children and families that were out of school for the past year. And I do think that what we've learned over the past year is that we can have schools open safely. The layered mitigation efforts are really, they work. Layered mitigation strategies work. And so, if schools are able to implement those directives, then I think we can have schools open safely. And we've seen that in other places around the country and around the world. So I personally, and from a professional standpoint, really strongly support keeping kids in school. I think that schools should be, the last to close and the first to open, because I think it is such an important space for kids to be able to be in. With regard to, evidence from around the country, there's very little evidence of there's very little evidence of in-school transmission occurring. We do sometimes detect cases in kids who are at school, but that is the result of transmission in the community. So somebody, has attended a family gathering or gotten infected from somebody else in their household, or been to a sporting event. They may get infected with COVID. That's community transmission. They may then come to school, but in schools where we've implemented these, layered mitigation strategies, including anybody with symptoms, does not come to school, and wearing masks and doing distancing and cohorting and hand washing and good ventilation, all of those measures really work to limit the spread in schools. And the state of New Mexico and the state of Arizona are both offering school-based testing programs that I think provide a really critical extra layer of protection to help keep our schools safe. With regard to your last question about when vaccines should be available for children, we expect that will be within the course of the school year, and I hope it will be before the winter break, but we obviously, want to make sure that we have all of the data that's needed in hand. And I think the FDA will not make a recommendation, and the ACIP, the Advisory Committee on Immunization Practices at the CDC, will not make a recommendation until they're confident that the data in hand shows that the vaccines will be safe and effective for children. And when that happens, I'm going to be right at the front of the line with my daughter.
Thank you, Dr. Hammett. Committee members, any other questions? Dr. Hammett, could you furnish to the committee the aspects of what you're talking about in the school, the criteria? And that way we could share it basically with the other members of the council, and then hopefully to get it out to the general public to basically, I guess the reason I'm saying that is because I see a lot of young people not in school right now, and that bothers me. And so how do we then assure parents and other folks in the community that we need them in school? The other aspect, we hear and read articles about wildlife getting the COVID. And I'm wondering about house cats, the lap dogs. Could they be, I guess, part of the community spread? Not necessarily the community, but within families. Your thoughts on that?
Thank you, Honorable Chairman. So I'll be happy to share information about schools with the committee. I know that Dodie has adopted a Safe Schools framework that is posted on the website, which includes all of those layered mitigation strategies. And I agree with you that there seems to be a lot of disinformation in the public right now. And so as much as we can do to provide accurate messaging to the community, I think that will help to alleviate some of the concerns about having children be in school. So I'm happy to share that information. Your second question about COVID-19 and pets is one that we've been, it's one that we've been looking into really since the beginning of the pandemic. There are, a number of different case reports that a small number of pets around the world, including cats and dogs, have been reported to have tested positive for the SARS-CoV-2 virus. And that's mostly after, close contact, somebody in their household had COVID-19 disease. Based on the information that we have available right now, the risk of animals spreading COVID-19 to people is considered to be very low. But I think if there is somebody in the household that is sick, it is recommended to isolate that person, from everyone else in the household, including pets and other animals. But our current understanding is that, we think that risk is quite low.
Thank you, Dr. Hammett. Committee members, any other questions?
Delegate Begay.
Oh, such a Honorable Paul Begay, you have the teleconference floor.
Thank you, Chair. So, committee members, thank you for your report, Dr. Hammett. I know that the parents become alarmed here in my local area. I think they report on a weekly basis on students and virus contacts and things like that, mainly for parental information. When you look in Facebook, people become very alarmed, saying, things like, why weren't we told? If the teachers, we hear that teachers are not wearing face masks. We hear, all these different stories, accusations more or less, and blames and things like that. Is there a guideline or a reference that teachers use as far as protecting themselves, protecting the staff, protecting the students? perhaps if there is this type of guideline, perhaps we can share it with us, and we can use that also to address concerns that are raised by parents and individuals or students in the school. Again, I think the miscommunication about, of course, everybody loves their child. Everybody is protective of their child. And when they hear something, even one or two has been reported at the school, they will not allow their child to go back to school. What can we do? Or what can we say? What can we use to calm nerves, perhaps, that it is there. Also the thought about I've often read, do not send your child to school if the child appears to be parents and people assume that they got it from the schools. So you don't know where they got that from, but I hear you say that it is most likely picked up from the outside of the school, somewhere where there's groups of people. It's just my thought. How is there a guide that the school administration, teachers, faculty go by? I don't know if teachers not wearing face masks and things like that is true, but yeah, those are things that you read about. So of course, social media, you will get all kinds of bad so just my thought. Thank you.
Thank you, Honorable Begay. Dr. Hammett?
Thank you, Honorable Chairman So and Honorable Begay for those questions. Regarding guidelines for teachers, I think what has been published by DODI and NDOH for the COVID-19 Safe Schools framework really contains, the best practices that teachers can follow to keep themselves safe and their classrooms safe. Number one on that list for people who are eligible to get vaccinated is to get vaccinated. That's the best thing that we can do to keep, COVID out of our schools. And then wearing a face mask. I know that that's something that Navajo Nation has really, set an amazing example with for a long time in this pandemic, and that's very important to do in schools. And then keeping as much as possible, distancing, hand washing, making sure that people are, not coming to school sick, and doing as many things as possible in outdoor spaces or well-ventilated spaces. I think those are all important things that the teachers can do to keep themselves and their classrooms safe. So I think in terms of support for the schools when there is a case, the NDOH and the Health Command Operations Center case management team has worked really closely. There's a contact tracing team within that Health Command Operations Center case management team, and they have helped to develop policies and trainings for schools so that they can know how to identify people who are close contacts when there is, a case in the school. And like I said, I think, transparency is important. We do need families to, feel like the school is being honest with the data and communicating with them. We want people to feel safe bringing their kids to school, and transparency with the data is critical to that. But I think we also need to make sure that we're communicating well with the communities and with our families. And I think that's potentially where there's, some opportunities to improve what's been happening right now, so that families can understand that, the vast majority of the time, if an infected person is identified in the school that has resulted from transmission in the community, it's not in-school transmission. And schools try and prevent this from happening from health screenings and testing if they're doing surveillance testing programs. But if it does happen that somebody, comes to school and has the virus, there are all these other layered mitigation strategies to, help prevent any transmission from happening in school. It's, we've started to think about it as an analogy, like, weaving a basket, and all of the different mitigation strategies are layers of that basket. People wearing masks, people keeping distance, people getting vaccinated, all of those things help to prevent in-school transmission from happening. Families need to feel, confident in this, in the system and what's being done. And they need to feel confident about the communication that, if somebody is identified at the school that it is a case, that they will be notified if their child is a close contact, and that schools have policies and have been trained in how to identify close contacts. So most of the time, using all these different mitigation strategies, there shouldn't be very many close contacts if there is a case that's identified in school. So there shouldn't be that many people notified as part of a contact tracing investigation, which, and then, because there are not as many contacts, also is a way that we, prevent any potential spread in the school. But I do think, we need to continue to work to communicate about that effectively.
Thank you, Dr. Hammett. Committee members, anybody else have a question or comment? If not, then Dr. Jill Jim, how are you on the call? You're also listed as part of this particular report.
Yes, good morning, Chair. This is Dr. Jim. I am on the call.
So did you want to add anything else to what Dr. Hammett presented?
No, Chair, jag är mentionado the health and the Hhs committee members. Good morning, and those on the call. I'm not going to add anything on to Dr. Laura Hammett's report regarding the different variants that were in question. We do have their surveillance team that she might have mentioned, tracking the different sequencing of the different variants across the Navajo Nation. I don't believe every sample is being tested at this point due to the large numbers that we are seeing here in the Navajo Nation. So the surveillance testing is a limited capacity, or it is a capacity issue nationally. I think we're thankful that the team is able to provide variant information, because most tribal communities don't have the capacity to do sequencing on the samples for COVID-19. So I just wanted to reiterate that this is a unique opportunity that we have here to be able to say that certain strands like the Delta variant is dominantly being seen because of individuals that are being seen in these clusters that are coming out of these cases on an everyday basis. So I just wanted to add that information just regarding the sequencing and surveillance from the EPI team, along with all the health facilities that are participating and sending in their samples to get this sort of data out for us for the Navajo Nation. So
Thank you, Sateja. Dr. Jim and committee members. Any questions for Dr. Jim before we proceed to the next item? Okay. Committee members, what my thought is to wait on a motion till all the items regarding all the items in the report are dealt with, and then that's when we can motion to accept the report and vote on it. Committee members. So now we go to receiving report A. We can conclude A, and then B, COVID-19 response, gating criteria report. Presenter Del Yazzie and HCOC EPI team. Ms. Yazzie, you have the floor.
Agushi, can you hear
Mr.
me?
Yazzie, I'm sorry, yes.
Okay. Yate, Chair So, and the committee members. I hope you can see my presentation on the screen. If not, please let me know. We also shared it ahead of time, so hopefully you have it on hand as I go over the slides here. Oyate, Che Del Yazzie, Inishia. Cove, Arizona, they Ayisinasha, Ado Kapijinas, Shoholia. Adnek Eche, Ado Kintachine, Dashama, Ado Tachine, Ado Ashkan, Ado Maidesh, Gijne, Dashanala, Out I Tenenshla, Ado Navajo Epidemiology Center, Aje Etra Shananashish, Ado Department of Health, Aje Atis Bahayado, Gedesti, Aje. Somebody is I hear some background noise. I don't know who that is. If you can mute your phone, I appreciate it. Thank you. Auto EAD COVID epidemiology team, involved in that team, the teamwork and the activities, tracking COVID cases and other metrics every day. Tracking the numbers collected on Bani Kego. Ajay Lotra Shinanashishido. Yun team members, part of our epidemiology team. Thanks for inviting us to be on this meeting and also allowing us to do the presentation. I have some of the team members on the call, so if I'm not saying something correctly, they can chime in and correct me. So I'm human, so I'm not perfect. I make mistakes and sometimes I say the wrong thing. So I have team members, our team members are on the call, some of them. So please, team members, chime in whenever you feel like it. So so this is our gating measures, my Shanat Ani's Hhs committee. Navajo Nation gating measures, path to zero cases. The title, the time period for the data is 2-week time period. August 6th only, August 19th is our latest analytical report for the gating measures. And we do this every week. We update the numbers every week, covering a 2-week time period. So if I go to the next slide, before I really continue into the numbers, I just want to acknowledge our team, our Navajo COVID epidemiology team. This is an award that we received from Navajo Area IHS Directors Award. Miss Roslyn So, the award digi. Award in a cool Directors Award. Dia, and here, just a little picture here with names. The award is for excellence in disease surveillance, data analysis, and data sharing for Navajo Nation. The some of the team members' names here. This is not a full comprehensive list of our EPI team, but some of them are here. Arotia, our Navajo Epidemiology Center team. Kojo, the pictures. On the right side of the listing, we have a large EPI team that contributes to the COVID epidemiology work every day. And we have meetings every day going over our COVID epidemiology response activities. So one is our Navajo EPI team. I think we should all, as Dr. Jim mentioned, you know, I think the Navajo Nation is fortunate to have a Navajo Epidemiology Center. Our leaders, I'm not exactly sure, maybe President Taylor McKenzie, that's it, back then, Epidemiology Center. I think I really we should feel fortunate to have an epicenter, to be doing the type of work that we're doing. So I feel blessed to be part of the EPI team, so the epicenter. We have members, they're on the call too, IHS, Navajo Area IHS, we partner with THOs, Tribal Health Organizations, the 638 facilities on Navajo. CDC, the CDC Foundation, Johns Hopkins Center for American Indian Health, Dr. Laura Hammett and her team. COPE, Community Outreach, Patient Empowerment, they're part of our team as well. TGen, AHOA, Dr. Hammett mentioned them. They're helping us with the COVID strain surveillance activities out of Flagstaff. Last and not least, but the State Departments of Health from Arizona, New Mexico, and Utah. This is where we get a lot of our data every day, especially the COVID cases that we compile every day. So this is our partners for our whole epidemiology team. I want to recognize them and acknowledge them for the Hhs committee members to really, recognize who are the makeup of our COVID epidemiology team. So I'll continue. So this is actually, let me put it on full presentation mode. So this is our gating matrix. This is what we follow based on the numbers that we analyze every week. You see different colors here, purple, red, orange, yellow, and green. The far left column, these are the metrics or the indicators that we track every day. Cases, testing capacity, public health capacity, hospital capacity, and we also compile some vaccine data as well. So this is what we follow as far as where we are as far as Navajo Nation, the COVID situation, and based on the numbers that we have, which color we fall into. So this is our recent cases and trends. Navajo Nation cases, it's a 60-day time window here, this chart. So more of a recent timeline is why we do this. So as you can see, these bars, the gray bars, have increased over time. all the way up to August 19th, that our last day of analytical day. And as you can also see, this red line, which is our 9-day weighted center moving average. As you can see, it's going up as well over time in the past 60 days. So, and then our infection rate, the reproduction of COVID, cases, infection in Navajo is at 1.12. And this has remained stable for about, I'd say, 3 weeks, but we are above 1. This is our case incidence across Navajo Nation, the number of cases over a 7-day time period from August 13th through August 19th. So over that 7 days, there were 308 new cases, which puts our incidence rate at 194 cases per 100,000 people over a 7-day period. So that's actually in the red level of the matrix that I just showed. So that's why this box is red. And our transmission, according to CDC's threshold, our transmission is high on the nation. And then spatially here, the COVID case burden here as a map, our bordering states, Utah, Colorado, Arizona, and New Mexico, they're all seeing increase in COVID cases over a 7-day period as well. And therefore they're in the red, which means their incidence rate is at 100,000 plus cases over per 100,000 people. And then on the nation, you see these Hhs service areas. They're all red except Shiprock. But we are seeing cases here throughout the nation. As even we look at data at chapter level as well. So we are seeing cases throughout the nation. Some additional metrics that we look at, as I mentioned, testing capacity. We look at a 7-day test positivity rate. Our latest percentage for test positivity is at 8.3. This has increased over time as well. The previous time period was at 7.6, I think. So it went up, we're above 8 now. So it did go up. The testing across the nation has increased over time as well. We're close to 900 average daily tests are being conducted over a 7-day period. So the last reporting period was 775. So it increased by some 100+ tests every day for 7 days. So testing has increased across the nation, and it's a good thing. Hospital capacity, for now we remain below 80%. I know there's yesterday's Hhs call. There were some, especially TMCs. Tehoto was mentioning they're at 88%. So we're going to reevaluate this come Monday. And I'm not exactly sure if we'll still be below 80%, but at least for now, as far as we know, we're below 80%, which is the threshold for hospital bed, regular beds and ICU bed capacity. Contact tracers to daily new case ratios at 3. There's 3 contact tracers currently for every new daily COVID case. We really like to be above 5, and we're below 5. So I know our partners are really working hard to bring on some additional contact tracers. Currently, it does take some time to bring on some of these contact tracers, but I know they're working on it to bring up this number above 5. So, and then this is our epidemic curve comparing the US in blue and orange, Navajo Nation. Over time, all the way from last March of 2020 to August 19th of 2021. As you all know, we've gone through a couple of waves, and we're trending upwards currently, perhaps our 3rd wave on Navajo. And now the US in blue is really going up as well, COVID cases throughout the US. And of the 308 cases that I mentioned over a 7-day period, comes out to about 44 cases a day for over a 7-day period. So we are, see this 40, this vertical axis here is for Navajo, the orange line, and the one over here is for the US. So for us, we're seeing about, 40, 44 cases a day for the past, I'd say perhaps a month. So our cases have really gone up. This is also a bar chart that we do, incidence of new cases over a 7-day period from August 13th through August 19th. Comparing Navajo Nation here in yellow to the 50 states and a couple jurisdictions. So we are at, I think, 32nd position, the last reporting period. So we've been hovering around low 30s position for a couple of weeks now. As you can see, the red bars are this Arizona and New Mexico, Utah, and Colorado. So that's our latest 7-day incidence bar chart comparing the US to Navajo Nation. This is the NNS3, the strain surveillance that Dr. Hammett kind of went over. This is in partnership with TGen out of Flagstaff. And I know Dr. Jim also alluded to the fact that I think we are Navajo Nations also very fortunate. I think that our nation has this surveillance project ongoing. And of course, there's a lot of partners involved in doing this and getting it off the ground and to continue to do this project. So we're at report 17 is the most recent latest report, which was August 25th, which is just 2 days ago, Wednesday. The latest report came in. So we have these two columns, report 16 comparing to 17. So the alpha variant, which is the UK, went from 148 to 155. There's still no beta variant identified on the nation. And then the gamma variant remained at 7. And the Delta variant, which of course we're all very concerned about and tracking, it stayed at 59 as well. And then the beta gamma went from 4 to 9. The Delta epsilon went from 55 to 187. So I think my understanding, I'm not a surveillance sequencing genomic person, but my understanding is that this Delta epsilon and the beta gamma are, it's hard to distinguish which one it is. So when they initially send samples to TGen, they do an initial PCR assay, and the PCR assay identifies it as a variant of concern as either Delta or epsilon. And it's hard to distinguish between the two. So after that, they do sequencing, further sequencing to really distinguish between the different variants. So this week and ongoing, they'll be doing these further sequencing on these variant of concerns to determine which one it really is. So we're at 187, and some of them probably will turn out Delta. So it'll go to here. I'm assuming the next reporting, the next report. So there are currently 417 cases on Navajo Nation that are identified with a variant of concern on Navajo Nation. This is just the variant profile for the US off of the CDC website as of August 21st. As you can see, this orange bar is all just Delta and making up about 98.8% of all the variants of concern across the US. So it's almost all Delta currently across the US. This is a 7-day incidence rate across the US. As you can see here, the southeastern states of the US are really seeing an increase in COVID cases. And then just raw numbers, number of cases over 7 days. Again, this is CDC tracking data tracker. Again, on the southeastern states are really seeing a high number of of COVID cases. And within our region, and Arizona is the only one that has this darker shade of blue color, meaning they're seeing a higher number of cases than the Utah, Colorado, and New Mexico, at least within our region. Community transmission across the US is pretty much all red, meaning the red is high transmission. And then by counties, I'll just go over the within our region, all the counties that are within Navajo Nation are red, and meaning high community COVID transmission. And then this is the latest high risk chapters list over a 2-week period. And there are 36 chapters that make the list. And these are chapters that had an increase in cases over a 2-week period, which put their incidence rate at greater than or equal to 100 cases per 100,000 population for 2 consecutive weeks. And that's how a chapter makes this list. So just for simplicity, these are the chapters that really saw an increase in COVID cases over a 2-week period. And then Dr. Hammond kind of alluded to this, drivers of transmission, our contact tracers are doing some amazing work by, tracking the cases, doing all the tracing and filling out these critical incident reports over the past 2 weeks. At least what we have is a lot of the drivers of transmission is due to off the nation travel, faith-based events. There were some Bible camps that occurred. The one that I'm pretty much familiar with is just south of Gallup, near I think Red Springs. I can't remember the name of the ranch. I think it's checkerboarded, so I think it's off the nation, but there's a ranch there. I can't remember the name of the ranch. Sorry, but
Is it Jones Ranch?
No, it's a
Broken Arrow?
Broken Arrow Ranch. Yes, thank you very much. There was a youth Bible camp that occurred there, and a lot of people from throughout the U.S. came, as well as people throughout the Navajo Nation attended. I think there were over 200 people who attended that Bible camp, and a lot of the cases emerged from there, from that event. And then also family gatherings, a lot of them are occurring for different reasons, birthday parties and other family related events. So these are the 3 main drivers of transmission as far as we know of today. So, and then I'm almost done here. So recommendation, risk level assessment here. Our cases are high. We're in the red level. Our cases continue to be going up, likely driven by the Delta variant. Our test positivity has been increasing over time, and hospitalization is increasing as well. And the main drivers of transmission is family events and faith-based events, and off the nation travel. As of now, we don't really know. We aren't aware of any evidence of transmission occurring in schools and business settings, like grocery stores or gas stations. So, I mean, there are exposures that we hear about, but as far as really transmissions occurring within those settings, we are not aware of currently. And then last, this is, where are we right now on the nation as far as our gating metrics? Our cases over a 7-day period, we are in the red. We're above, our incidence rate is at above 100 cases per 100,000, so that's red. Our testing is at above 8%, so we're in that, it's orange. And then our contact tracers is currently at 3, so we're below 5, so we're in the red. But as I mentioned, people are working on bringing on additional contact tracers currently. Then our hospital capacity, we're at least for now below 80% threshold, so that's orange level. So, and then we follow this statement down here. We follow the CDC guidance for thresholds for gating metrics or measures. If 2 indicators suggest different threshold levels, as is the case here, there's red and orange. the higher level is selected. So for that reason, we're in the level red. So that's our gating metrics update. Chairman So and my my other Hhs committee member and the leaders. And I'm going to stop here, Chairman So, and I don't know if there are any questions. Thank you.
Thank you, Mr. Yazzie. Committee members, any questions for Mr. Yazzie? If there are none, then the chair has one. The ones that the age group that are testing positive, do you have them separated by age group and gender? Mr. Yazzie.
Yes, Honorable Chairman. So I'm going to pull up our COVID dashboard, and I'm going to share our dashboard where the data is separated by age groups and by gender. So if you'll give me like 10 seconds, I will share my screen. This is also our epidemiology team. Create every day. We call it a situation report. This was yesterday. SIT report for short. This is our 532nd report. So we've been at this for, as you all know, we've been at this for a long time. This is 532 report as of yesterday, and we list the total number of the cumulative number of COVID cases on the nation, which is 32,430 as of yesterday. So yesterday we reported 55 new cases. And then I think there were 15 new recovered cases, if I remember correctly. 30,633 cases have recovered from COVID. So if you divide this by 32,430, usually comes out to about 95% of the cases have recovered from COVID. So, which is a good thing. And then we reported one new death. So we're right at 1,400 total cumulative COVID deaths on the nation as of yesterday. And then here are the testing numbers that we also collect every day. Then here are the cumulative COVID cases by border town and by Hhs service areas. Chinle with the most cumulative COVID cases as of yesterday, and Winslow service area with the least. And this website you can go to, and it's interactive. You can click on each of these service areas to give you their own bars and curve. But this is throughout the pandemic chart for Navajo Nation. If you hover over the bar, it gives you the number of cases for that day. And then this red line is our 7-day average curve, where, as you can see, we're currently, that red line, that curve is going up here on this chart and the website. So going to the question by age groups. So here's COVID-19 by age groups. This column here is the by age groups. And then the blue is male and red is female. And there you see the percentages here by age group, by gender. So if you look at this, the age group from 30 to 39, if you combine the male and female, most of the cases are from that age group. And by gender-wise, they're about even, 50% male and 50% female. So this is the profile for COVID as of yesterday. And this bar chart over here is for the deaths, again, by age groups, and then by age groups and gender. And then the last two bar charts down here is for border towns. Border towns for COVID cases by age groups and by gender. And then deaths for border town cases by gender and age groups as well. So this is the our SIT report that we do every day. And on this one is we added this recently when we started the strain surveillance for COVID. You see the latest numbers here as well. And you can go on this website to track the latest numbers or the latest SIT report that we submitted. So I don't know if that answers some of your questions or your question, Chairman So.
Thank you, Mr. Yazzie. If you could send that to the committee, that would be helpful. Appreciate.
Yeah. Okay.
Okay. And perhaps Ms. Cook could, you could send it to Michelle Cook, and she could share it with the committee. Committee members, any other questions? Thank you, Mr. Yazzie. Then we would now go to.
Chair, this is Delegate Slater. Can I ask a question?
Honorable Slater, yes, you have the floor, Sitzela.
Thank you very much. My question is there any way the 7-day moving average could be broken down by age group?
Yeah, Honorable Slater, yeah, I believe that is possible.
Okay. I think that's something that'd be helpful for leadership to see. And also perhaps for families if they recognize that transmission is relatively low among young folks and then also within school settings.
Yeah. Yeah. We can generate some charts for that and share with the committee.
Thank you, Mr. Yazzie. So now we can go to COVID-19 fully and partially vaccinated. Navajo Nation resident vaccination rates as well, broken down by service unit and area vaccination rates. Ms. Rosalind So, are you on the call?
Hi, good afternoon, Chairman. So this is Hhs Yazzie with the Navajo Area IHS. Unfortunately, Ms. So had a governing board meeting as well as other area senior leadership, but I will be assisting for the next two items. Thanks.
Okay, you have the teleconference floor, Mr. Hhs Yazzie.
Okay, just wanted to confirm that you guys could see my screen. Okay. Well, again, good morning, and thank you, Che Markiyazi and Shia, Hotsoi Nishlento, Kintlachitni, Dashite, Tsayagonichi, De Nasha, Do, Not Nijoj, De Eshagon. And good afternoon, everyone. My name is Marquis Yazi. I serve as the Director for the Office of Indian Self-Determination with the Navajo Area Indian Health Service. And again, on behalf of area leadership, Ms. So was not able to be in attendance, but she does give her regards. And again, thank you for joining us today and for the opportunity to provide an update on our ongoing work across the Indian Health Service. I do want to thank Delegate So for his leadership as chairperson of the Health, Education, and Human Services Committee, and each of the committee members for your continued leadership and support. Our working relationship with the committee is vital to ensuring we continue to work in partnership and that you are kept abreast of important issues and concerns. But again, I would like to thank you for your continued support and commitment as we work together to improve access to healthcare across the Navajo area. Today, I'm joined by subject matter experts as well as various service unit leadership who will provide updates and participate in discussions. But before we get started, I'd like to begin with a few major updates on our response to COVID-19. Across the Indian Health Service, we continue to focus on administering as many COVID-19 vaccinations as possible. We recently reached another milestone within the Indian Health Service, more than 1.5 million vaccine doses to patients, employees, and tribal and urban community members, and over 59% of our American Indian and Alaska Native adult patients have received at least one vaccine dose, and approximately 49% have been fully vaccinated. There was a recent article in the Los Angeles Times about the high rates of vaccination among American Indians and Alaska Natives. And across the Indian health systems, our work in promoting and administering vaccine across our communities is paying off. However, as the Delta variant continues to spread, we still have more work to do. But I would like to thank each of you for the significant roles you have played in achieving these results and ensuring vaccines are available to community members and patients throughout our communities. With regard to FDA, which granted full approval to Pfizer vaccines, earlier this week, we received more good news when the FDA announced that it has fully concluded its thorough and independent scientific review of the Pfizer vaccine and granted full approval for people 16 years and older. Adolescents 12 to 15 of age may still be vaccinated under the emergency use authorization, but we also look forward to the CDC finalizing the FDA approval by incorporating it into the routine immunization schedule recommendations as soon as next week. And this is another key milestone in our nation's fight against COVID-19. The FDA approval is the gold standard. Now that it has been granted, those have been waiting for full approval should join the more than 200 million Americans who have already rolled up their sleeves and gotten vaccinated. But again, we continue to urge and keep encouraging vaccinations and masking to prevent further outbreaks in areas of substantial and high transmission rates. But again, let's continue to work together to combat COVID-19 and to reach community immunity. With regard to special general memorandum that was recently issued, the IHS established a IHS policy regarding requiring COVID-19 immunizations for all personnel working in IHS healthcare facilities, and healthcare workers and other employees in federally operated IHS healthcare facilities have until October 1st to complete their COVID-19 vaccination. And this directive is aimed at providing the health and safety of our workforce and patients, and the vaccines are the best tools to achieve this goal. With more than 4.5 billion COVID vaccine doses administered nationwide, we have enough data to know the vaccines are highly safe and effective in protecting against severe diseases and hospitalizations. I believe Dr. Jill Mose, Director of Public Health, and Lieutenant Commander Erica Harker will also join us later to provide a more in-depth update on our COVID-19 response activities and answer any questions you may have. But with regard to tribal consultation, I'll provide a brief update on our recent consultations and confer activities going across the agency. Last month, Principal Deputy Assistant Secretary Brian Newland at the Department of Interior and the Indian Health Service initiated a tribal consultation on the Indian Self-Determination and Education Assistance Act 105L lease requirements and payments with a goal towards consistent and transparent lease administration. So that is also going on today, which overlapped with this meeting, but you're welcome to, we'll provide the technical notes and any follow-ups on that particular issue. And also, IHS recently initiated a tribal consultation and Urban Confer to seek input and recommendations concerning modernization of the health information technology infrastructure supported by the IHS. And this follows the Dear Tribal Leader letter that was sent on April 1st that provided the agency's decision to move forward with full replacement of the RPMS system, or the Resource and Patient Management System. In June, the IHS hosted 2 listening sessions on the topic for tribal and urban Indian organization leaders. The IHS has also released a request for information for interested vendors. So we continue to receive written comment and recommendations on this topic by September 6th. And also, the IHS is seeking input and recommendations on IHS's mandatory funding approach. And this complements the tribal consultation recently initiated by the Department of Health and Human Services. HHS held 2 virtual tribal consultations on this past Wednesday, August 25th, and the next one is on September 1st. So let me know if you would like more information on that. I also want to thank you for your participation and input over the last few weeks on recent HHS Region 9 tribal listening sessions. The purpose of HHS regional consultations are to provide tribal leaders an opportunity to consult with HHS leadership on various national level issues by discussing programmatic and policy issues and concerns. Through the HHS consultations, we have heard various ways we can improve our consultation efforts at the Indian Health Service. And transitioning, in addition, in August of 2018, the IHS Direct Service Tribes Advisory Committee and IHS Tribal Self-Governance Committee submitted a joint letter recommending the use of a tribal federal work group to update the IHS consultation policy. And we have initiated consultation in response to this request and are requesting feedback, but it also is on the heels of President Biden's memorandum on tribal consultation and strengthening nation-to-nation relationships. But we are pleased to report that we held our first IHS Directors Advisory Work Group on tribal consultation meeting on Tuesday. So I want to thank some of your participation, of all who participated at the tribal level, as well as federal members who have volunteered to serve on this important work group, and to provide a comprehensive review of the IHS's consultation policy and develop recommendations on improvements. And the work group will be meeting again on September 28th. And then with regard to the Community Health Aid Program, there is some great news to share about the CHAP. We are getting one step closer to expanding CHAP from Alaska to the lower 48. The IHS has announced 2 grant programs to support the expansion of the National Community Health Aid Program. The IHS CHAP seeks to expand access to medical, behavioral, and dental care by training and developing mid-level healthcare professionals who work under the supervision of a licensed provider. And currently, IHS is accepting applications for 2 CHAP-related grants, the CHAP Tribal Assessment and Planning Grant and the Tribal Planning and Implementation Grant. And both are designed to provide direct support to tribes seeking to integrate CHAP into their communities and build their infrastructure to expand access to care. So the applications are live on grants.gov and will close on September 6th. And we strongly encourage the Navajo Nation as well as the tribal organizations to apply to increase support as you continue to build your healthcare infrastructure. So this is an exciting opportunity for the Navajo area. So I look forward to working with you on that. But with regard to the B item, COVID-19 fully and partially vaccinated, Navajo Nation resident vaccination rates, as well as the service unit and area-wide vaccination rates. I'm going to turn it over to Lieutenant Commander Erica Harker or Dr. Jill Moses to provide additional information on that specific topic. Thank you.
Hi, thanks. This is Dr. Moses. It's actually Dr. Kettering who's going to be presenting the data. Thanks. I'll be available for questions.
Yat and Honorable Chairman, so the Honorable Delegates, Dr. Chelsea Kettering Inishia, Aldo Nishanigadi, Dashchi Inishla, Touching Ibash's Chin K, Ani Dashiche, Toglini Dashinale, Dakar, Lana Donasha, Ado, Matnishoja de Shevan. Hi, good afternoon. My name is Dr. Chelsea Kettering. I'm the epidemiologist for the Navajo Area Office. I'll go ahead and share my screen to present the agenda item B, the COVID-19 fully and partially vaccinated rates. Okay, what we're looking at right here are the COVID-19 vaccination status among Navajo Nation residents. This is looking at eligible residents on the Navajo Nation that have received the vaccine. Eligible residents are defined as ages 12 and older. This data is capturing the rates from December of 2020 through present day, through August 23, which is this past Monday. You'll note here that we have a total of 91,658 Navajo Nation residents that are fully vaccinated. Fully vaccinated is defined as a resident that has completed a two-dose vaccine series, meaning either the Pfizer or Moderna, or they've also completed a one-dose vaccine series, which is the Johnson & Johnson. Right now, we're looking at 49% of all Navajo Nation residents are fully vaccinated, whereas 60% of eligible Navajo Nation residents ages 12 and older are fully vaccinated.
Dr. Kettering, this is Dr. Grimm. I don't think this is fully approved by the UCG, so I don't know. I would like to just stop there until to now. I just wanted to make that known. Thank you.
Thank you, Dr. Jim.
I think the vaccine data on the gating criteria is approved for public information. Thank you.
Hey, thanks, Dr. Jim. I think that's what we have prepared. So if that's not what's approved to share, then we'll need to postpone presenting slides. We'll let you go ahead and provide the rest of the update.
No, there was a slide with the percentages. The one that has the 71% and the 65% is that we're not looking at Navajo Nation residents. That's the data that I think it is approved for public information. Thanks. Dr. Kettering, is there a slide that just has it has everybody else? Thank you.
Hi, good afternoon, Dr. Jim. No, we do not have that information available.
Proceed as best you can.
I am unsure of which slides were being referred to or data sets.
I think it's the one you had just relayed.
The presentation I had showing, Dr. Jim noted, was not approved by the team.
Yeah, isn't the second slide not where it doesn't show Navajo Nation residents only? That includes Hhs boundaries, like vaccines given across Navajo Nation and service unit.
We do have a slide on, yeah, there's the second slide. Go ahead, Dr. Kettering, with that, I guess.
Okay, thank you, everyone. This is the second slide that we had available. This is the Navajo area Hhs COVID-19 vaccination status by the service unit and tribal health organizations. This represents all ages. You'll note here that it's a representation of all of the service units and tribal health organizations within Navajo and the vaccine rates that we are seeing. Again, this data covers the COVID-19 vaccine distributions from December of 2020 through August 23rd, a couple days ago. You'll note here that all these service units are below 60% fully vaccinated, which implies that there is greater than 40% of the Navajo Nation community that is not vaccinated and is at greater risk for receiving COVID-19 virus. Moreover, in conjunction with Dr. Hammond had alluded to earlier, our teams strongly suggest an increase in public health messaging to support coming in to get vaccinated. And this is also a snapshot of the record level data that we receive weekly from each of these service units and THOs.
Dr. Kettering, is that conclude your presentation?
Yes, sir. Thank you.
Okay, just for the record, I think, Honorable Slater, are you connected by Zoom? And I think the balance of the committee is by teleconference, as I am too. So we didn't get the slides unless you share them with Michelle Cook, and then she can forward it to legislative staff and the committee.
Yes, both slides were provided to Michelle. I will have to reach out to Michelle to remove the first slide that was presented earlier so that only the second slide is shared.
Thank you. Now we go to let's see, proposed ARPA 2021 expenditures for COVID-19 response. Dr. Jill Jim and Ms. Rosalind So, or in this case, Marquis Ozzie.
Okay, so now this is Dr. Jim. Do you want me to start first?
Yes, go ahead.
Okay, well, thank you again for that. We'll get the vaccine data. There are some numbers that are being separated for Navajo Nation residents and those in service units. And so we just want to make sure that we're clear about the data before we post it publicly. There have been some inquiries about the data. I did see a Navajo Times article about the vaccine data not percentages not being accurate. So I believe we would have to make a public statement at some point to say these are the official numbers. And there has been some numbers being reported slightly differently. So I just want to assure that before we go public, there'll probably be a formal statement because there has been quotes in the media that we were 99 or 91% vaccinated. And some of them were probably looking at the vaccines that are administered versus the other reporting. So I had to stop that just to make sure that we were clear, and we will make a public statement to give accurate data. So just wanted to make that statement first, Shana.
Yes, I was interviewed for that, and I basically had pointed out that misstatement on the data, but that part of the interview wasn't printed. But yes, yes, please. I think the 91% is highly misleading, and so it'd be good to get the correct data out, because there still needs to be some more vaccination to take place. Thank you. You may proceed, Deja.
Okay, I'm Dr. Jill Jim, Executive Director for Navajo Department of Health. Ado dona insne look on swan touching the chain do ishe the chain dot is a sonne the shanella. Ado the ARPA dollars, the American Rescue Plan Act dollars, and some are CARES Act dollars. I believe these are items that were given to Title I programs here with the Navajo Department of Health, and those are the Office of the Executive Director, Environmental Health, Kianta Public Health Nursing, Navajo Community Health Representative Program, as well as Division of Behavioral and Mental Health Services, are just some programs that are contracted under the Indian Navajo area, Indian Health Services, to provide services to the Navajo people. And these are contractual, or these are dollars that we will be receiving at some point to address the COVID-19. And for all of these items, for item number 1, for loss and reimbursement, and I think, Chair, if there are questions or maybe facilities might have inquiries, I know that Marquise Yazzie is the self-determination director that might have questions for clarification on what these items, what these categories can be used for. So Marquise, I think I'll maybe rely on you that in case that I'm not interpreting, or maybe since we have not done budget forms for all of these, we are still in the process of completing the documents needed to receive funding from the Navajo area office. I will just broadly talk about what it will be used for. So through the Indian Health Service ARPA dollars, there is ARPA dollars that are going through the Navajo Nation and also separate divisions. And through Indian Health Service, we are receiving these particular items. There might be some items that are not on here, but for loss reimbursement, I know that I don't have the right allocations. I know from ballpark figures about $15 million looking at either staffing, either reimbursements for third-party revenues, which we don't have. So I think there'll be other sort of loss reimbursement that we have to make sure that under the Department of Health, since we're a tribal program, we don't accrue third-party billing. We're going to have to find other ways, allowable expenses for that $15 million out of a little over $50 million that we'll be receiving to continue to address COVID. I think with healthcare services and purchase refer care funding as well, that's probably another item that as a tribal program, we probably need to figure out a way on how that particular item can be spent, because some of these are more clinical to that extent. I know that will have to still be explored and determine what is allowable under healthcare services. Information technology and telehealth, those are items I know that in the response to COVID and just regular services, Division of Behavioral Health has already begun looking at telehealth services already with their existing dollars, but I think we need to expand sort of the infrastructure for that. There are other dollars through the FCC, I think through telecommunications. They are working on with CHRs to make sure they have broadband availability when they're out visiting clients, and making sure they have the sort of reception or broadband width or capacity in order to document patient encounters and visits to individuals in the community. So that sort of, and I think opportunity for those that are going out into the community and providing services, and also increasing our own internal capacity to do that. There are other opportunities that I still need to look into, but with regards to information technology and telehealth, I think that will definitely be part of our efforts here at the Department of Health, is looking at telehealth and CHR capacity as well. And the vaccine planning, distribution, monitoring, and tracking, of course, there are a lot of efforts that are going on here with the Health Command Center through the public health messaging group. We do currently take, we pay for the KTNN forum that was done last night, sort of that media part of the response, and also any sort of billboards that will be coming up regarding even monitoring or supporting vaccine administration will be our effort. Since we don't administer vaccines, I think we're mostly going to be here to try to publicize and encourage individuals to get vaccinated. Some things that have been brought up in our Health Command Operations Center is just the idea of providing incentives to individuals. I believe that at some point we did receive supporting documentation from the area office that some of these dollars do support, and was recommended, or not recommended, but allowed to support incentives as well. And so that has been on the table, but we have not explored that option as well with this particular account because we haven't accessed it. So those are sort of our plan is on the Navajo Nation side. We'll look at opportunities to support community or Navajo Nation-wide activities. I believe that the health facilities do receive funding for their individual areas, but I believe this would be the way we will be approaching the Navajo Department of Health, and we have, to the extent possible, looking at the Health Command operations where we have 638s and Health Indian Health Service at the table planning with us on how some of these items would need to be supported. So for vaccine planning and distribution, that would be sort of the effort on our end, supporting the entire Navajo Nation. Testing and contact tracing and monitoring and mitigation will continue to look at opportunities. There are an ongoing need for contact tracers, and I know with the last Indian Health Service CARES Act dollars, we're going through the process of finally paying our contractor and then finding new training opportunities and in regards to looking at the Navajo Nation as overall effort in either providing opportunities that way. But I know when these dollars came about, one of the strategies that I recommended was just to look at how do we utilize our resources we're all getting the same pot of money, but how are we implementing it locally? And I think that for this approach, even with contact tracing, service units have hired contact tracers and they're continuing to provide ongoing testing. I know we will try to fill in the gaps and look for sectors in the community to try to bridge those, like for testing. We do have now that vaccine mandate from the executive branch, and we'll support that. And then also with the assistance from Arizona Department of Health providing us resources. But that's where we're at. It is part of a whole pie that we all fit into these puzzles. And I think from Department of Health, that's what we're planning to do with contact for testing and contact tracing. And then of course, monitoring and mitigation will require providing our internal capacity to continue to do the required testing and the vaccine mandates as well. So that's part of the intention of the item here for testing, contact tracing, monitoring, and mitigation. In regards to public health workforce, and that's always an ongoing need, and that is a national agenda that we always are, that was always being brought to the table to community leaders. And it's interestingly common to see different federal agencies supporting public health workforce, but where does it really fit? And how do we think about the public health workforce? Because we often get this question from CDC as well, saying, well, how can CDC help the public health workforce? And then with Indian Health Service is through ARPA dollars, it says here is funding for supporting the public health workforce. And so I think this is a valuable item that needs to remain long-term. And I know that we do have a healthcare system where there are clinical services that are being provided in hospitals, but there's also more services that are also provided by tribal programs. And I think that is how the nation is set up, but there are still some public health workforce in hospitals. And so I think bridging the entire workforce and the need for this and individuals that are out there off the reservation. And one thing that I would like to see is the Navajo Nation posting positions for teleworking or working from home sort of thing. We know we have talented individuals, but I think one of the dilemmas that we have is there isn't enough housing for people to come back that's either affordable or within distance. And so maybe that's one thing that we ought to look into. And I did mention something similar, not public health workforce, but with Doltex, I did mention, well, why do we make the ombudsman part part telework and part coming into the office. And I don't know if federal agencies, I think, are temporarily doing that, but maybe there are positions that are more towards that direction. I don't know, but that's something to explore because and they probably want to contribute. And during the pandemic, when the numbers were really high, a lot of them were wanting to help for free or volunteer in that way, but we didn't have a net mechanism for it. So I would like to figure out how to expand our public health workforce of people that do have the skills and such as epidemiology, biostatisticians, but those need to be sustained long-term, and the funding within these are only a couple of years. So I hope we can build our own capacities and ask for sort of that sustained funding because of this pandemic. So I just want to share my viewpoint on the public health workforce. And regards to mental health and substance abuse prevention and treatment, I believe that is going to be a couple of $1 million over $20 million per se in this funding pool to help expand services to our people. And I hope we are able to continue to work on building the Division of Behavioral and Mental Health. I did make a selection for the position for the Health Services Administrator for that division. So I hope that all the paperwork will go through and we will have a permanent full-time person for the Division of Behavioral and Mental Health Services soon that can be announced. But I did make a selection in that interview. And I think that particular part with the behavioral and mental health is an ongoing concern with the pandemic. And we would have to bridge health facilities with Division of Behavioral and Mental Health Services. It's not initial though, it's not initial Asian with Audea. So I always think that when we say things in Navajo, it means something more better than saying collaboration or partnership. And I think that's the thing that needs to happen across all health facilities with the division in order to get people referred and have better care coordination, because our people are going to need a lot of help. And the other thing we lack, of course, is just these permanent structures with limitations in our existing funding. I hope we can find ways to, with other ARPA dollars, to build and construct new facilities so people can be referred to locally rather than off the reservation. So there will be a large effort on this part. And I know that my selection of individual, I think, has the capability of handling this particular task and making sure that we do meet the needs of our Navajo people. The next one is detect, diagnose, trace, monitor, and mitigate COVID-19 infections. I think, to me, this is really a large open-ended funding pool here. And to me, there are things that we're not capable of meeting, and we don't have general funds right now to cover COVID-19. So all of the response that we're doing here at the Department of Health under the Health Command has been under the Health Management Services contract we have with the Navajo Nation. And that includes sort of this open-ended statement here, because sometimes we have to get emergency food. We do have the donation funds. We're using that right now for COVID-19 patients, working with division of our Department of Emergency Management. So because we don't have the account set up, they're able to help us get emergency food for COVID-19 patients. And these are food boxes that are being requested by patients out there that the hospitals are identifying. So anything to do in that way, and also continuing to pay for like Tinley Unified School District, the space, the lease there for us to have to be able to operate out of there. We are not operating any sort of services out of there, but we do have equipment out there and PPE that we still have, and also maintaining sort of the ongoing response here at the Wellness Center. So that particular item, it's to meet our daily response to COVID-19. So I always look at this one where so there are certain things that aren't available in the other areas that help us mitigate. So I appreciate that particular item that we will continually use as well to respond. Isolation and quarantine, there isn't particular funding indicated just for isolation and quarantine, but we know that in the last round when we offered isolation and quarantine, they were up to running a 25-bed hotel operation with full wraparound services, meaning medical staffing, food, and an emergency ambulance on standby. I mean, literally, I think costs around $2 million a month. And that is something that was something that we explored here for the first time. And we look forward to finding out ways for how health facilities can work with this, because under the FEMA major disaster declaration, this can be supported through tribal health organizations as well, to building their capacity to provide isolation and quarantine services. The amount of funding that was available to provide these services were underutilized in some areas and utilized in more areas. So I think there would need to be a really careful consideration on how the nation will fund this moving forward, ensuring that people do use the facility and they're not sitting there with empty beds. And so I think that was the concern, where we did go into several communities and we paid millions of dollars, and there were some patients just didn't go, or maybe weren't referred, or maybe it wasn't explained to correctly. So I just want to reiterate that particular isolation quarantine for the Navajo Nation. We're really, I'm waiting to see what health facilities will be doing in order for us to invest in isolation and quarantine. And other tribal communities, what they do is tribes sometimes pay for the right wraparound services, and medical staffing is done by the hospital, so there isn't really a high cost and it's more efficient. So that's at the table for discussion. We know we started those conversations, and then we are monitoring that question. Last week, I think not a lot of health facilities on the 638 sites were seeing a need for isolation and quarantine. I don't know what that need is today, but I know that FEMA capabilities are available for 638 facilities. But in the Navajo Nation, for me, we have not identified funding to commit to, and I think there would, as I mentioned, careful consideration. School screening for COVID-19, I have not set aside any dollars for school screening. I know there is a resource that's available through the Arizona Department of Health and Human Services that we're making sure that we are we're ensuring that their proper protocols are set in place between the state of Arizona and Navajo Department of Health, working together to ensure that if kids are screened at these health facilities, that their information is kept confidential, and we're in compliance with just protecting individual information. And that is a government to government function that we are looking into. Although there is an immediate need, I think when there is samples being taken from kids, we need to make sure that the proper processes are in place. Especially if they're going to be going across several schools. Of course, they would have to be they would have to present to and receive approval at the local level to do that. But the Navajo Nation Department of Health has not set aside funding for school screening yet, and I'm also waiting to see what gaps we'll see from the health facilities and other BIE funding, and then see where the need is to help out these schools that need screening. And we are beginning to hear that BIE has initiated their own contact tracers and possibly maybe doing their own screening. Then if that is the case, I would like to suggest bringing BIE to the table to provide their plan to the Health Command Operations Center, so there is no duplication and there is transparency across and communication and identifying cases in those schools. So school screening is very important, and right now I'm just waiting to see through our Health Command Operations Center to see what other facilities are doing before I allocate any resources that could be duplicative, and I want to avoid that as much as possible. So with that, Chair, that will end my report tonight. Yeah.
Okay, long so Deja. Committee members, do you have any questions?
Chair?
Slater. Oh, Honorable Slater, go ahead.
Thank you very much. Dr. Jim, can you talk about some of the issues in compiling accurate vaccination rate information for the nation and go into more detail on that? And then in terms of coordination across the tribal health care organizations, IHS and Navajo Nation programs, what are some issues and areas or opportunities for change either via Navajo Nation policy or things that you're working on right now? I think you touched on some of them, but if you could consolidate into one answer, I'd appreciate it. Thank you.
Chair, can I speak now?
Oh, go ahead, Deja.
Okay, Shannon. Although Honorable Slater, thank you for that question. The vaccine effort that we're doing, we would need compliance from everyone to basically report their vaccine information on an ongoing basis, and we do have a raw data list of all the records, which would provide better data to show by age and if they're a Navajo Nation resident or not. But that would need to be compiled on a weekly basis, and that would mean facilities would have to export their data of all the people that receive vaccines. And now we're into booster shots, and those have to be documented in a timely manner to say every Friday we have to get data in order to report out on Monday or by Tuesday that this is our vaccine rates, and for us to make better decisions on those that are not probably getting the vaccine. So targeting unvaccinated individuals, and I think we're working on a template, but that would be the effort is for facilities to be submitting that in a timely and weekly basis to the Navajo area office. And so we do have Dr. Kettering and Ms. Adekai there and other team members. We do have a vaccine surveillance group to receive data and making sure that if we want accurate data by that Tuesday, we shouldn't say that one facility didn't report, so we're just reusing their number. There has to be consistent reporting, especially now that we have the vaccine mandate, that we should be, these numbers are going to become very important, not only to the legislation that's being proposed for vaccine mandate, but the executive order information as well. What we can't get is probably the detail level data that I'm talking about vaccine mandate is if they're from the enterprise or if they're a school employee, that might be difficult to get. But I think overall numbers, we should be seeing slight increases and fluctuations over time and targeting those individuals. It's getting more difficult. We're not going to see, and for a while we were really stagnant. And so, but we have finally begin to receive most hospital information except for the New Mexico satellite clinics, which really has not supplied any vaccine rates to the Navajo area office, even though that we had provided a memo months ago, and also trying to work with the Albuquerque Indian Health Service office to report the vaccine data so we can have an overall picture. And we don't want to say the Navajo Nation, but these clinics, we don't have their data. And that's what we tend to say because because not everyone is reporting the entire piece of the pie. There's things that if there's a missing facility, I think it makes it hard for leaders and anyone to say that this is where we're at with our percentages. So I think it's very important that we do get full reporting from the facilities on a weekly basis. And I just want to thank you for raising that question so we can ensure that that's happening. But right now we are missing the New Mexico satellite clinics and most of our data and our vaccine reporting. Although I can say that they're a small percentage, but that's not an excuse. We need everyone to comply with the reporting so our numbers are more representative as well. And then in regards to coordination and regards to policy changes, I think one thing that I just mentioned is just fully being, it's not on this, and to this day, I think sometimes I always think about, what does that really look like? I think that's one thing to describe when I think about when I hear the word coordination and other so it's part of that. I think what I'm looking for in that perspective is understanding what the capacities are for these health facilities so we can figure out how to give resources or provide cheap resources or even shuffle resources across the Navajo Nation. Because one thing that we're going to encounter is these medical shortages, the staffing. And we fortunately have not said that our hospitals are overwhelmed, but what will that really look like? We will respond. And I think what we need to do across the health facilities, doesn't matter if you're 638 or a federal facility, there needs to be a plan a backup plan to say, and I think there is, but we haven't really used all of our toolkits. We are the largest land-based nation. We have the most people, and then we have probably the most challenge in doing this because of our way our healthcare system is structured. But I know we can do it, and that goes back to I know we're capable of it. So I just would like to answer your question that way, Honorable Slater. I don't know if I directly answered it, but I'll end my comments there. Thank you.
Honorable Slater, do you have a follow-up?
Not right now, Chair. Thank you.
Okay. Committee members, anybody else? Basically, Dr. Jiljan, is it the satellite clinics, is it because there's funded through, and I don't know I can't remember the funding scheme, Navajo area, IHS funds, does that go to the satellite clinics or is that come from the Albuquerque area funding?
Here, this is Dr. Jim. They go through the Albuquerque area office.
Okay. Okay. Would a letter from the committee be of benefit to try to get the Albuquerque IHS to share their numbers, because I'm sure they're reporting their vaccination rates to the Albuquerque IHS office. The other is, I know that there's not a like the IHS hospital in Albuquerque. They're very limited, and a lot of the residents from Albuquerque, Rio Rancho, and the urban areas were going to Toajile health clinic to get their testing and their vaccine. So I'm aware of it because the folks from Torreon and Ojo Encino in community meetings have basically said that that was the way they handle their getting tested and their shots in an almost immediate manner. And so the other is there were remote vaccinations, like at the Cuba Checkerboard area health clinic in Cuba. And I don't know if they're reporting to the Crown Point IHS. So those are some things that I think we really need to get a good handle on. And again, how can the committee be of help? And how do we even get the 638 healthcare facilities and to report on a weekly manner, because we do need good data to actually be saying we're at 68%. So that would be how I would ask and place the situation to you. How do we help?
Oh, yeah, and on to not. I think there could be a supportive memo to remind the facilities to give their electronic health record data of all the individuals vaccinated on a weekly basis to the Navajo area office. But as a committee, I think it would benefit too if you receive their individual hospital vaccine rates too as well for the 638 facilities or area office. But I think that, well, that's being done at the area office anyways. And I think you can also put in the memo as an oversight, instead of the hospitals giving you data, I think there can be a directive to the Navajo Department of Health with the health HCOC vaccine surveillance team to give you that weekly breakdown by facility, their vaccine data. So I think that would be our most appropriate thing to make sure that there is compliance, but you also receive a report from the Navajo Department of Health as well. Yeah.
Thank you. Okay, we'll work with Legislative Council to draft such a memo. Committee members, any other questions? And let's, that completes 5A and B, all related. And I'd like to get a motion to adopt the combined reports before we go to item 5C, committee members.
Sure. I'll make that motion, and then I'd like to include a directive that whatever the report was from IHS that needed to be fixed, be submitted or get fixed and be submitted to the committee and to our advisor, and then it can be distributed out to the council. And the same thing with any other written reports from MDOH.
Thank you, Cecilia. Committee members.
I'll second that motion, Delegate Bajay.
Oh, siya lang sa check. Committee members, appreciate the attention to this particular aspect. It is a big concern. Ms. Nota, could you give us the roll call vote on this particular item? 2 items.
Okay, Honorable Paul Begay Jr., how do you vote?
Green.
Honorable Paul Begay Jr. votes green. Honorable Pernell Halona, how do you vote? Honorable Carl Slater, how do you vote?
Green, Delegate Slater.
Honorable Carl Slater votes green. Honorable Charlene So, how do you vote? Honorable Edison J. Wanika, how do you vote? Honorable Edison J. Wanika, how do you vote? Honorable Pernell Halona, how do you vote? Honorable Charlene So, how do you vote? Honorable Edison J. Wanika, how do you vote? Chair, you have 2 in favor, 0 opposed, 4 not voting, which is including Honorable Chair Daniel So not voting, Honorable Pernell Halona, Honorable Charlene So, and Honorable Edison Wanika not voting, Chair.
Committee members, we've lost quorum.
This is Wanika. I vote green.
Oh, okay. Thank you, Cecilia.
Yeah, I will be off now. I was trying to get a hold of Pernell. He's supposed to get on.
Okay. Thank you.
Yes.
Oh, Hakushila, I know we're really just pulled in several different directions. It's been a hectic week. So at this time, I'd like to call to the table the Navajo Hopi Family COVID Relief. The presenter is Ms. Ethel Branch. Ms. Branch, you have the floor. Star 6.
Oh, I'm so sorry for that. Thank you. Thank you for noting that. Yeah, honorable committee and chair, thank you so much for the opportunity to speak today. Can you guys hear me now?
Yes.
Hello?
Yes, we can hear you.
Oh, good. Oh, good. Great. She'e Ethel Branch and Chef Pipatwantly, Michelin, Nakai Bashas Chin, Sint Dasha Che, Do Nakai Dashanala, Sezizi Dena Shah, and Kintana K. Hashte. I'm the interim executive director of Navajo and Hopi Families COVID-19 Relief Fund, which is a DBA of Ye Ha'omido. And I really wanted the opportunity to speak with you because I'm greatly concerned about the status of COVID in our community right now. The nation has been thrust into a really tough situation as nationally we go through this Delta wave. And that wave has now arrived to Navajo, as I understand, and as I'm observing in the data. So our team has been tracking Delta since April, kind of tracking the Friday to Friday statistics in terms of the new cases for each week. And for quite a while, for most of May and much of June, we were holding steady at 50 new cases per week. And then we hit this really beautiful low point in the fourth week of June where we had only 20 new cases, which was really surprising because that's when we were starting to see a national rise in Delta cases. And then the first week of July, that new case number doubled from 33 new cases to almost 70 new cases. So that was our first hint that something was happening with Delta in our community. And then, of course, the third week of July, our new cases jumped to almost 200 new cases per week. That number dipped back down to 100 the fourth week of July. And then for August, the numbers jumped back up to 200 new cases per week and have held, steady at that level until last week, in the period from August 13th to August 20th, the new cases per week doubled again to 400 new cases, over 400 new cases. And, thankfully in the last week, new cases are for the week are at about 258, but that's still really high. And we haven't seen numbers this high since February, when we were kind of coming out of that winter, the really dire winter wave that really the only thing that saved us there was the introduction of the vaccines. And you can see that trend in NDUH's COVID data dashboard for the daily confirmed cases on Navajo and all in that particular graph. So, Delta is here, and it's a pretty dire situation. We are on an exponential growth pattern with cases doubling, new cases doubling every few weeks. I'm really, really concerned. We've been in close contact with a number of medical professionals on Navajo Nation, just in an informal manner. And we have learned from one of our contacts that, we got some information about what's actually happening in the hospitals. From this particular contact noted that the hospital this staff member works in was almost full for the past 2 weeks. They were having difficulty transferring their patients because all the regional hospitals in the Four Corner states are full, and those hospitals are not surging up. They're not closing their operating rooms and other non-urgent parts of the hospital in order to accommodate Navajo's surge. And those states are kind of closing out they basically peaked for Delta, but we have not yet peaked. Our peak is probably not going to be reached until the end of September, based on estimates and intel from folks who are watching this closely in our healthcare system. And very disturbingly, they're observing severe breakthrough infections. So that's a case where someone is vaccinated, but they get COVID anyway. And they're also seeing an alarming amount of those breakthrough infections with our fully vaccinated people. And they're starting to see more and more children coming into the hospitals with bad cases of Delta. And so the expectation is that trend of seeing more and more children is going to continue growing. So we are greatly concerned here at the Relief Fund, and we think now is a pivotal moment where we need to get ahead of this wave and try to mitigate damages, minimize damages in our community. And, we've heard a lot of information about Delta variant just now. I'm just going to let you know what I understand, and I've been tracking this in the news very closely. Delta is highly, highly transmissible. Alpha variant was 2 times more transmissible than the original Delta or original COVID strain. Delta itself is 2 times more transmissible than the Alpha variant. People were saying at the beginning of August that it was just as contagious as chickenpox, which is, as you know, extremely contagious. But the to give you some context, there's something called an R0, and that's kind of the number of people that someone who is sick is likely to infect. So the R0 for original COVID was 3. So someone who got COVID back in the last spring or last fall was likely to contaminate or pass on the virus to 3 other people. The R0 for Delta is 7. So you can see, the level of transmissibility is much more high with Delta. And what we've been hearing in news reporting is sort of like this tag where people are referring to Delta as something that's affecting people who are younger and, younger, sicker, quicker. That's kind of the tagline that people are using with respect to Delta. It is tending to affect more children. It's really going after unvaccinated people. And our children who are under 12 obviously cannot be vaccinated. And it's quicker in terms of the onset of symptoms happening within as few as 24 to 36 hours. And of course, people declining. We spoke with someone who was observing that, a medical professional who was observing that previously you might expect to see people in the hospital for a number of weeks before they expired from COVID, but with Delta, that time is basically cut in half. So it does seem to work much more quickly. And in terms of the vaccines have been really great. We started out at like 80, 90% efficacy rate, but in the face of Delta, it's only effective about 50% of the time, 50 to 60% of the time. And that's why you're seeing so many breakthrough infections among people who are fully vaccinated. I think, it is true that the symptoms for Delta remain the same among the unvaccinated people, but what is really concerning is that among vaccinated people in the breakthrough infection context, the symptoms are presenting differently. They're presenting as milder, colder flu-like symptoms, or they're not presenting at all. So, people who are fully vaccinated are sick with COVID and don't know it. But the unfortunate thing about Delta is that if you have it, whether you're vaccinated or not, you are just as contagious as anyone else who has Delta. So we have a situation where someone can be fully vaccinated and have Delta and not know it because they're not experiencing any symptoms and be passing it on to people just as much as someone who is unvaccinated might be. So that's partially why Delta is so highly transmissible. But as we all know, like the vaccine, even though it's not as effective against Delta, it still does work very well against severe infection, though it's not 100% of the time. In terms of the data, 97% of patients hospitalized with COVID-19 are among the unvaccinated. Someone doesn't have their mute button on.
Yeah.
A little background noise there. And of course, the unvaccinated are 2 times more likely to become hospitalized. And then in terms of deaths, 99% of deaths attributable to Delta are among the unvaccinated. So I agree, it's vital that everyone get vaccinated because that's, even though it's not as effective of a tool now in the face of Delta, it still is an effective tool in saving people's lives and mitigating damages. So I agree, we need a lot more strong public messaging out there, letting our people know that Delta is different and it has stripped away a layer of protection that we had with the initial vaccines. My understanding is that the booster is going to be made more widely available in our hospital system on September 20th. So now is the time to send out the message for people to double down on their COVID precautions. Urging people to stay home, to stay safe. I would even urge families to keep their kids home from school for this month while Delta surges so they can avoid transmission to their kids. And that is a message that I heard the president articulate on Tuesday in terms of recommending that folks do digital learning for for the time being. And then, of course, just letting people know that regular masks are not as effective against Delta because it's so highly transmissible. People really need to be wearing, especially, immunocompromised and elders, they need to be wearing KN95s, and they need to be wearing close-fitting masks. If they don't have KN95s, they need to be double masking and making sure that, it's the 3-ply mask with the cloth mask over it, and it's close-fitting. Otherwise, they may as well not wear a mask when it comes to Delta, because Delta will get through those openings in their masks. And then another important message that we put out there is for families to create bubbles around their children. Like if they have to go grocery shopping and they can't leave their kid at home, they can surround the unvaccinated child by family members who are vaccinated. And everyone, of course, should be wearing the KN95s or be double masked. And so, in light of this context, the Relief Fund has decided that we're going to have to adjust our budget. We were hoping that everyone would get fully vaccinated. That's not happening. And so, we were hoping to move on to long-term resiliency-based work, like opening community centers, but we're having to move some of that funding around to do a Delta response. And so, again, if people can just mute their phone if they're not presenting, that would be really helpful. In terms of the
Staff,
response
Branch, can you wait for a
we're-
moment? Staff, can you please mute all the phones right now? Or if you can recognize the one that is making the noise.
Again, this is Regina. I have Mr. Kuntz here. I also have David Schultz. I have Ms. Rainey Nelson, and I have Honorable Delegate Edison Winika in the room.
Delegate Wadika, can you please hang up or mute your phone? We can hear the meeting that you're participating in within 2A.
Okay, basically, everyone, this is Rex Kuntz. Thanks everyone for attending.
Okay, well, I'll
Who from
just
the
try
staff
to.
is running the line right now?
Honorable Slater, it's ending number 212. I don't have access to mute the number.
Was to move water to a higher zone and serve a number of homes.
Okay.
So it's Julissa
All right.
Johnson co-host, and then
I think he
Okay, this
muted.
is Lorraine. I muted that person. Thank you.
thank you.
Okay, great. So in terms of the response that we're going to be launching, we're going to provide isolation assistance to families that have a sick family member so they can stay home and we can avoid community spread. And so that'll include, of course, food, water, and PPE. We'll be including the KN95 oximeters so people can monitor oxygen levels, no contact thermometers so they can monitor temperatures without risking exposure within the family. And then, we'll be taking those help requests through our phone hotline and our online help request system. We'll be issuing PSAs and notice of this assistance on radio, newspaper, and social media. And then we'll be doing some outreach to public schools to see what their needs are. We have received requests for help with PPE from some Arizona public schools. Apparently, they didn't receive funding for adequate levels of PPE. And so we're really concerned about that. I mean, that is something, it would be great if the Navajo Nation could make sure that, because I don't know what the cost is going to be with respect to that, but the kids are going to need so many different things like the wipes, the dividers, the hand sanitizers, the KN95 masks. But we're going to do an assessment and see where people are with things and we already have some donations mobilized. We have 60,000 8-ounce bottles of hand sanitizer coming from Providence that we're going to try to get into the schools in addition to our isolation kits. And we're going to start piloting, if we can find a school to work with us, a wristband system. In the schools, people can't ask if someone's vaccinated, but we have these I'm vaccinated wristbands so that people who are fully vaccinated can wear those, and there can be situational awareness in the classroom in terms of, who is vaccinated and who's not, and how safe the situation is for the students. We are also going to be mobilizing donations and volunteer seamstresses to either purchase the masks or the Clorox wipes, or to sew the masks so we can get those to the kids. Let's see, we had already launched a pro-vaccine campaign, but we're going to be adding $50 gift certificates as incentives for folks who are unvaccinated. You know, if they will go get vaccinated within 2 weeks of speaking to us, we'll give them a $50 gift certificate. So potentially, you know, if it requires 2 rounds, potentially they could earn $100. And then, so that's kind of what we're doing. And again, we really wish we didn't have to do this, but we do believe that this requires a quick response so that we can avoid or minimize damages in our community over the next month as Delta peaks in our community. And, you know, I do hope that the committee will consider and council will consider reimbursing us for these costs through ARPA funding. And so, you know, because again, we've had to move money from our budget from other programming, long-term resiliency-based programming, in order to provide this immediate response. And we're happy to do that, happy to contribute to protecting our community, but we would love to be able to continue doing those long-term resiliency-based activities for our community as well. So I do want to just put that request out there. And that's, you know, basically my update and sort of my assessment of the situation. I'm very thankful to hear that Department of Health will be drilling down on the data and letting us know, you know, what percentage of vaccination we actually have in our domestic population on Navajo Nation. I think that will be really, really helpful in terms of understanding how to try to motivate our community to get to 100% vaccination levels, and how to make sure that people are securing access to the booster when it's made available. So Hhs, honorable committee members and chair, thank you so much for making time for me on your agenda.
Thank you, Ms. Branch. Committee members, any questions for Ms. Branch? Okay.
Sure, this is Doug Slater.
Oh, Honorable Slater, you have the floor.
Sure. Thank you very much. Sorry, I have someone trying to fix my internet right now. I have a request to both Dr. Jim and to Ms. Branch, and that is, can we try to work toward a detente and have both the HCOC and the Uniform Command Group reach out to a lot of the private organizations that have set up, including the Navajo Family COVID Relief Entity, and try to maximize the impact in our communities by working together. I think that there were some issues in the past, and I just see a new Navajo year coming up, you know, this time period as we enter into the later fall. And it's a time that maybe we can renew our relationships and try to move forward in a good way together. But I think just like in public policy making, it's good to have some healthy skepticism of the assumptions and the conclusions we come to and try to really verify them. This would be a way of doing that within our policy making, but also, you know, providing greater transparency on the numbers that we have that are generated out of Navajo and helping them get disseminated to all of our people. So the committee can help facilitate that. It'd be great. And I hope that my colleagues are mindful of the request that Ms. Branch just made, that in the presentation the group had provided before to the Navajo committee, they mentioned that, or they mentioned a concept of I think a resiliency fund that Navajo NGOs could use. And as we move forward and
setting up our fiscal relief funds in the next month or so. I think that'd be a really valuable use of the Navajo Nation's ARPA monies because it's having this direct impact in our communities. So just a couple requests, and don't really expect any responses right now, but something to maybe meditate on for a week or so as we move forward. Thank you, Chair.
Thank you, Honorable Slater. Anybody else? Committee members? Thank you, Ms. Branch. We will, I guess, basically send us a briefing page of what you presented, and that way we can share with the 24 members of the council. And that way they have the $50 incentive is something that could be a driving force. Thank you.
Great. Honorable Chair, and Honorable Delegate Slater for Vice Chair for your comment. And we're absolutely happy to work with HCOC or Uniform Command. We would love to be able to partner in making sure that we're getting this isolation assistance to folks who are in most need. So absolutely, I would welcome outreach from Dr. Jim or her staff to try to facilitate that. And Honorable Chair, I will get you the briefing paper that you've requested as soon as I can.
Okay, thank you. Committee members, I rushed the presentation as we were about to lose quorum, and that's how come. Part of the thought was each of the IHS facilities, as well as the healthcare, the 638 healthcare facilities would have given us a short report on the use of the ARPA funds, but because we were going to lose quorum, I rushed it. So one of the items that, if those folks are still on the line, I'd like to ask for a written update on the use of the ARPA funds that they have already received. And so going forward, that would be and if it needs a memo, we will do the memo. Thank you. Committee members, a motion to accept the report from Navajo Hopi Family COVID Relief.
Motion to accept report, Delegate Agay.
Oh, thank you. Do I have a second?
I'll second Delegate Slater.
We have a motion and a second to accept the report. Ms. Nota, roll call vote, please.
Okay, Honorable Paul Begay Jr., how do you vote?
Delegate Paul Begay votes green.
Honorable Paul Begay votes green. Honorable Pernell Halona, how do you vote? Honorable Carl Slater, how do you vote? Honorable Charlene So, how do you vote? Honorable Edison J. Wanika, how do you vote? Honorable Pernell Halona, how do you vote? Honorable Carl Slater, how do you vote?
Delegate Slater, green.
Honorable Carl Slater votes green. Honorable Charlene So, how do you vote? Honorable Edison J. Wanika, how do you vote? Honorable Pernell Halona, how do you vote? Honorable Charlene So, how do you vote? Honorable Edison J. Wanika, how do you vote? Honorable Chair, you have 2 in favor, 0 opposed, and 4 not voting. Chair.
Okay, committee members, we have lost quorum, so we'll just have to end the meeting. But going forward, the only other item, we had a special request from Jim Squirline to address legislation. I don't know if the committee would want to meet. We don't have anything scheduled next week unless it's, of course, it's the meet and greet to meet the new regional director. I text Speaker Damon, says that should be an official NABI committee meeting so that we can place some issues before the new regional director and not just eat ice cream and cake with him. The other...
Sure.
Oh, Cecilia, go ahead.
Sorry, I didn't catch you. Which day were you proposing to have a special meeting? Was that Wednesday?
I'm not proposing. I'm just saying that Squirline was asking for a special meeting to address veterans housing. And since the budget doesn't start until October, the ones that, is being proposed in the new budget, next week, just the 30th and 31st is open. Then we're all going to be pulled in several directions. First, second, and third committee. We had also scheduled the work session at Richfield, and the Richfield dorm has relayed to Honorable Paul Begay that they'll be meeting on September 4th. So September 3rd would be travel. The work session September 4th. And then, of course, the holidays, and then the special budget session September 7th through the 10th. After that, then I think it's September 15th is the next regular test meeting. Committee members. That's how our schedule would go for the next 1, 2, 3, 4 weeks. What, Ayla? Chichedo sa Chile. Legislative staff.
Chair.
Oh, Che.
Thank you. I'm kind of leery about September 4th. That's Labor Day weekend. I don't know I know that the board had told me that they're meeting on the 4th, which is on a Saturday. But the actual Labor Day weekend begins on Friday. Friday, Saturday, Sunday. I'm not sure if we can
possibly the board members will be there, but I don't know about the city officials. That's what I'm thinking about.
All right. We'll let's put that in advance then.
Okay.
And in regard to that, Ms. Morris, can you address the committee? This morning, Ms. Laureen Spencer said that there was going to be 2 legislation ready, and perhaps we could, legislation 0176 is,
Yes, Chair.
Go ahead, Ms. Cook, please address the committee on 0176.
Yes, good afternoon, Chair, committee members. This is Michelle Morris with Navajo Department of Health, the legislative analyst. We posted legislation for our Department of Health issue papers to be presented to the HHS tribal consultation. They're going to be ready for action on 8/31 next week. We would like to request a meeting for those papers to be presented to the committee. And the number, I'm sorry, the legislation number is 0176-21. Chair.
Okay. Committee members, I'm reviewing the email that Coraline, and I don't, Miss Jalissa Johnson, are you on the call by chance?
Yes, sir, I'm here.
Thank you, Miss Johnson. Jim Swerline emailed the committee this morning regarding legislation 0177. When would that particular legislation end its 5-day comment period?
The legislation 10177-21 will be eligible for action on August 31st, which is next Tuesday. And the first committee it's assigned to is the Health, Education, Human Services Committee.
So committee members, we could request for a special meeting to address what Ms. Michelle Morris highlighted to the committee, 176 and 177 committee members. So what I'll just do is have staff write a letter for a special meeting on the 31st. And then we won't worry about the trip to Richfield. Ashako.
Oh.
Hakoshi. Since we lost quorum, we'll just end the call. Miss Spencer and Miss Nota and Miss Johnson, thank you for being on the call. Oh, yeah, it's not us. You're on the call?
Yeah, I'm on the call. I'm on 2 calls.
You have an earbud in each ear for 2 different meetings, so.
Yeah,
Okay.
I'm on the public hearing right now as well. And,
Zoom
just
call.
your call there on the HES committee meeting.
Okay, thank you. All right, committee members, since we do have quorum with Honorable Paul Begay, Honorable Carl Slater, Honorable Wanika, and myself, we do have a quorum. If I could have a vote to request a special meeting for August 31 to address 176 and 177.
I'll make that motion.
Honorable Paul Begay motions to request a special meeting. Do I have a second?
Halona.
Thank you, Honorable Halona. We do have a motion and a second. Ms. Cheryl Nota, please do the roll call vote.
Okay, Honorable Paul Begay Jr., how do you vote?
Green.
Honorable Paul Begay Jr. votes green. Honorable Pranay Halona, how do you vote?
Halona votes green.
Honorable Pranay Halona votes green. Honorable Carl Slater, how do you vote? Honorable Carl Slater, how do you vote? Honorable Charlene So, how do you vote? Honorable Daniel So, or Honorable Edison J. Wanika, how do you vote? Honorable Carl Slater, how do you vote? Honorable Charlene So, how do you vote? Honorable Edison J. Wanika, how do you vote? Honorable Chair, you have 2 in favor, 0 opposed, and 4 not voting. Chair.
Okay, we lost quorum again, so I'll just sign the memo. Committee members, this meeting is adjourned. Thank you, legislative staff, legislative council, and all the folks on the call. Appreciate your attendance. I apologize for losing quorum.
Chair, did you call the meeting? Meeting adjourned. Did you say meeting adjourned?
Lost the quorum, Mr. Halona. This is Lorene. The only
Okay.
2 members plus the vice chair, which makes 3, but there was only 2 voting, so lost the quorum. Thank you.